Good morning, dear friends. It's such a pleasure to be present in this unique conference, unique concept of obstetric emergencies, which actually are required on massive scale if we want to target the SDG goals and MDG, which we have not done till now. We do talk of many other things in obstetrics and gynae which are not required to such an extent. So I am thankful to the organizers for making me part of this whole exercise where we really want to reduce the obstetric complications. Now, coming on to this topic, this really has been interesting. Why? Because there are so many other conditions which primarily are more important for reducing the maternal mortality. But we have realized that liver disorders are no less, in the sense not so much in the volume, but in the kind of magnitude of challenge to the obstetricians which they are. Very often there are other conditions which can be managed, but very often liver diseases still are there in large numbers. Now, this actually was an actual case few years back where we had there was this woman who was unbooked, unsupervised, admitted with 41 weeks of pregnancy with an intrauterine demise and jaundice. At the time of admission, the patient was stable, patient was moderately ecteric, the labor was induced and the labor started well. So coming to, if you look at the first two lines, the obstetric team was fairly comfortable. Nobody was worried about it that something undue would happen. The investigations did show altered liver functioning status, but not so bad that everybody would be alarmed. However, after 8 hours, even though the patient delivered normally, but she became drowsy, disoriented, and when she was observed, this happened to be the early morning, when now she was seen, the consultant observed that the patient was very deeply jaundiced. The patient rapidly went into shock and could not be revived. Now, the challenge was that the previous day's evening's resident who had admitted, they stuck on to, ma'am, she was ecteric, but she was not that bad. And the morning team said, no, you must have missed it. Now, this is the scenario which we very often, actually we have not been present all the time, so it is a challenge. Acute fatty liver of a pregnancy is actually relatively unknown, uncommon condition, but yes, it has been recognized to be a very potentially fatal condition. Even though it was first described way back in 1940 and was called as yellow atrophy of liver, the incidence still is not very frequent. It may be 1 in 10,000 to 1 in 15,000. Some people even say 1 in 20,000 pregnancies. So that way it is not so uncommon. People have started recognizing and dealing with it, and as a result of that, even though the mortality earlier was kind of for 75%, but has reduced to 18% now, and the perinatal likewise also has reduced, but still is a challenge. Clinically, if we find, just go over it, it usually occurs in 3rd trimester, rarely in 2nd trimester, but it may sometimes present at early postpartum disease also. And the worst thing is that the presentation varies according to the severity. Initially, a woman may just have anorexia, nausea, vomiting, which can something be like normal pregnancy feature, or maybe mild liver dysfunction to begin with. And very rapidly, the woman may develop fever and jaundice, more ecteric, tenderness in upper abdomen. What is worse is that very soon she may present in encephalopathy, GI bleeding, pancreatitis, acute renal failure, and coagulopathy. And the worst part is that the transition from the mild form to the severe form is sometimes so drastic that it does not give us even time to diagnose. The effect on the fetus is also detrimental because there is maternal metabolic acidosis. So the baby may get severely compromised and sometimes intrauterine demise may be there. But what we are actually struggling with it, what causes it, and how can mother be saved. We really do not know what caused it, but gradually we are understanding as to what is the etiology. Recent molecular advances suggest that actually there is a mitochondrial dysfunction. It is associated and found to be having an autosomal recessive disorder, and there is an LCHAD deficiency in some women. When it is there familiar, then there may be recurrent AFLP in these women. Now, sometimes this is an interesting concept that if the mother is herself not suffering from this problem, is just a carrier, but the fetus present inside her is a deficient one because the husband or the partner is also a heterozygous one, then in those cases, the hypothesis says that unmetabolized free fatty acids of the fetal circulation come to the maternal circulation and may be producing precipitation of the problem in the mother. This is new area, and then they are trying to work on it, that actually we should start looking for infants who have got this deficiency. Now, the pathophysiology happens to be that there is progressive lipid accumulation. Normal fat content of the liver is about 5%, while in this disease it is about 13 to 19%, and this leads to the major problem. There is increased ammonia production. Classically, they have hypoglycemia, and which is sometimes the clue to diagnose this condition. Associated, there would be coagulopathy, obviously liver failure would be there. There is hepatocytolysis and atrophy of the liver. So, the liver usually would be small and soft and yellow, unlike what we expect in hepatitis or other conditions where you feel that this would be enlarged. Of course, there is a microvesicular fat infiltration, which is not just restricted to the liver, it occurs also simultaneously in other organs like kidney, pancreas, bone, brain, and that's the reason why we have multi-organ dysfunction very soon. Can we predict this? Now that we do recognize that this is an entity, can we start predicting it? Because very often we will have more women, or we should be able to diagnose more women. So they have said probably LCHAD deficiency, if you know in somebody, it would be a good idea, it may be. But others are just clue. They have been found to be more in older women, women who are primigravida who have low BMI. But this actually doesn't help. It's also been found to be more associated with preeclampsia. This also doesn't help. If the fetus is male, this doesn't help at all. How do we know the fetus? Multiple gestation has been one clue, and they say that in multiple gestation, the incidence can be 14-fold higher. So yes, all the women who have got multiple pregnancy and are showing the pattern of some liver dysfunction, be on guard. They may be having this problem, or they may land up in this problem. Some people have said that there is actually only one case report has been there, that acetyl salicylic acid use has been associated with this. But this statement has to be used with lot of caution and guard, because we can't generalize this. Of course, the fetal and neonatal outcomes are bad, as we mentioned earlier also. Maternal complications which actually harm and cause lot of morbidity and mortality are not just the liver dysfunction directly, but others, for example, renal failure, which may occur in as many as 84% of women, infections, coagulopathy, hypoglycemia. GI hemorrhage is another problem which is found in these. Of course, stillbirth is associated. These women may have severe PPH and fulminant hepatic failure, of course. So the diagnosis is always challenging, simply because, as we have understood, according to the severity, in a matter of 12 to 24 hours, the picture may be very non-specific to begin with. It is mimicked by many other conditions which are much more common. Hence, you will always think first of them like acute viral hepatitis, preeclampsia, HELP, and intrahepatic cholecystitis. And the worst thing which makes this challenge more difficult, especially when you are waiting for investigations, the reports to come, is a very acute presentation and progression. Ultrasonography would be able to give a better direction if you can do it just then, not for just obstetric reason, but for liver, looking at the liver infiltration. Now, liver biopsy, which has been considered as the gold standard for diagnosis of AFLP, is ridden with lot of problems. In the sense, no, there is no doubt about in histopathological picture of this disease. But the problem is, do you always get a time and opportunity to do this liver biopsy, to get a diagnosis and then to alter the management? Very often it is left as a method just to, in retrospect, confirm that yes, this was AFLP, or maybe for medico-legal purposes. There would be many laboratory findings which may help you. Usually hemoglobin and hematocrit may be normal, TLC may be raised. The enzymes, as can be expected, are also raised. Important again is that the glucose levels would be less. There may be alterations in the liver function and of course, alterations in the kidney functions associated with these, they would be of help to you. Now, as has been mentioned, Swansea criteria has been made. It has been proposed by the UK Obstetric Surveillance Group. Unfortunately, it has still not been validated, even though it has been included in the guideline. Any 6 of the below mentioned points, if are present, then this gives that yes, the criteria is positive. The percentage of times they would be present are mentioned in the bracket. This is available. We can just use this as a routine ready reckoner to at least all the cases who have got jaundice to find out till the reports are coming of other viral tests and etc. to find out, to get some clue at least that if this is present. As I mentioned earlier, liver biopsy was established way back in 1995. It was considered must, but because the times coagulopathy is associated with this problem, this is a big hampering condition. And hence now it is considered that it is not mandatory. And what in fact should be used as a clue for diagnosis is a woman having jaundice progressing fast, if has viral markers negative, which we must emphasize on getting early report, we must think of the AFLP as the condition which may be present. Liver biopsy is indicated, of course, in those conditions if in postpartum period, if she has lived out of it, the liver function are not returning to normal. Sometimes in early stage, if you have a facility, do a liver biopsy, the patient is not very serious, you have time, then terminate these pregnancies. Remember friends, because in viral hepatitis etc., we never hasten the process of termination in pregnancy. This is one condition which would definitely improve if you terminate the pregnancy. Histopathologically, of course, when you have done the liver biopsy, there would be not macrovascular but macrovesicular steatosis, pericellular pallor, lobar disarray, and of course, oil red O staining is used, but this is not a worry to us. The histopathologist, the pathologist would be. The management mantra would be high level of suspicion. Think of this, low threshold for admission in all these women who have got viral markers absent and jaundice present. Of course, there may be some cases of intrahepatic cholestasis also coming into your this thing, but it's okay if you overdiagnose or try to overtreat. And this is a multi-speciality management. So the whole thing relies on an early diagnosis and prompt delivery. This is very important. Prompt delivery is the only thing which can make the difference, and of course, an intensive supportive care would be required. So the moment you catch hold of a patient, or if you suspect, do an appropriate counseling considering all those level of morbidity and mortality which are going to be there. Stabilize the patient, correct the fluid, and what is important is correct hypoglycemia. They may sometimes need 50% glucose administration also. Delivery of fetus is must. In UK, in fact, they recommend cesarean section when they find that it is rapidly. Hemodynamic stability is very important. Some people have said that N-acetylcysteine may be used. Nightmarish complications are the same. Again, these are being repeated, and they are real nightmare if they occur. Refractory shock, coagulopathy, hemorrhagic pancreatitis, irreversible liver damage. Sometimes they may have liver rupture and liver necrosis also. People have tried liver transplantation in acute cases, and in fact, over 16-year period in United States, 8 cases were done for this particular condition. To summarize, acute fatty liver of pregnancy is an uncommon but potentially fatal complication of pregnancy. Diagnosis is a challenge because presentation is non-specific in initial stages and is mimicked by many more, much more commoner conditions. Message is liver biopsy is not mandatory, even though may be advised sometimes for decision making and medical legal purposes, but don't wait for the results of this. Supportive care and expeditious delivery remain the best treatment. Thank you, dear friends, for giving me that.